success with the other one. So.
Okay, very good.
Perfect. Well, I'm glad you could make it. Thank you, everybody, for taking the time to join us. I'm Morgan Hofarth. I'm the president of the Registered Nurses Association of Ontario. Happy Nursing Week, everybody. I'm very much looking forward to hear about the advanced practice nursing presentation. So why don't we waste no more time and we'll jump right into it and let our very distinguished presenters introduce themselves and start their presentation.
Okay. Are you going to introduce us, Irma Jean? Or?
Sure, I'm very happy to. And I just wondered, before we got started, Sarah, if you just wanted to maybe introduce yourself, and it's a time for you to rah-rah nursing.
Well, thank you so much for that. I'm it's an honor to be connecting with you and to learn a little bit more about the work that you've been doing. I know I've had a chance to, when we were able to meet in person, to connect with our local chapter as well. And, you know, I just want to thank you all for the wonderful work that you're doing. I think, you know, now more than ever, people are valuing our nurses and our healthcare workers in ways that they maybe didn't before. And so I just want to thank you, because I know it's been a particularly difficult last year, and there are many challenges in the sector, and I know we're going to discuss those today. But just know that you have an ally here that's ready and willing to help in any way that I can to amplify your voices and make sure that we address the ongoing challenges, whether that's in staffing, you know, pay gaps, staffing ratios. All of this, I think, are areas that we want to focus on. And maybe just a little bit about myself. You know, I am the member in Brampton Center. I also serve as a deputy leader for our party, the New Democratic Party, and I'm the critic for long-term care, home care, and seniors, which I was recently appointed to, and so still learning quite a lot, and I'm glad that we have a chance to connect. But for me, I was born and raised in Brampton, and so when we speak of the larger healthcare conversation, Brampton and Peel Region, frankly, have been ground zero for hallway medicine, and really understanding those gaps and the fact that we haven't received our fair share ever is kind of one of the reasons that I got into politics, was to help address the healthcare crisis that we have in the province of Ontario, but in particular in the community of Brampton. So I'm glad that we're able to have this conversation today, and definitely looking forward to continuing the advocacy as we move forward. But thank you again for the opportunity.
That's just terrific. And thank you for mentioning that you were the long-term care critic. And we're delighted, because really we do need those who are able to focus on this sector, especially at this critical time. So I'll have you move the slides, and then I'll introduce our three attending nurse practitioners who are going to really take you through some key aspects of the role of attending nurse practitioner, and really a day in the life of an attending nurse practitioner. So with us today, we have Wendy Dunn, and Wendy is an attending nurse practitioner. So she is a registered nurse, as well as prepared as a nurse practitioner, and she works in that role at Greenwood Court and Knollcrest Lodge. And by way of interest, Wendy has a resident count of 120. So her role actually is really the ideal, according to all of those advocacy statements that RNAO has been making, one attending NP per 120 residents. Next is Kaitlan Laviolette, and Kaitlan as well is a registered nurse, prepared nurse practitioner, also has a gerontological nursing certificate, and she is the attending nurse practitioner at Holland Christian Homes, and that home is a best practice spotlight organization, which I'm sure you've heard about, and she's the BPSO lead. And then our final attending nurse practitioner is Jean Benton. And Jean is a nurse practitioner as well, a registered nurse prepared and nurse practitioner. She's an attending nurse practitioner at Marion Hill Long-Term Care, and community services in Pembroke, Ontario. And Jean has a number of years of experience as a nurse practitioner and in the attending nurse practitioner role, and numerous stories to share in relation to the kind of impact nurse practitioners have had. So let me turn it over to Wendy, who will start us off.
Yeah, hello, Sarah. Thank you for taking the time to meet with us today. Have you worked with nurse practitioners? Do you know what a nurse practitioner is?
I have not worked with a nurse practitioner. I have an understanding of the work that you do, but I would love an overview and would appreciate that.
Okay. And I noticed in our introductions, I am actually, you would see they had NPs-PHC, that stands for primary healthcare. I actually have my adult NP. So there's a few different types of nurse practitioners. We're all masters prepared now. Years ago we weren't, but that's all changed. So we're all masters prepared. So have a BSCN. In registered nursing, we need to work for a few years. I think it's 2 years full-time hours now before you can go back and do your master's of nursing now. And then there's different streams we can take. So there's a primary healthcare stream, an adult stream, which is what I did because I was always interested in geriatrics only and don't have me look after kids. Then there's a pediatric stream, and I believe there's an anesthesiology stream as well. I actually don't know anybody working in that field, but I do think there's that stream as well. So that's kind of how we're prepared. And then we work at an advanced scope. So when I talk to patients or residents about what I do, I say I am a nurse and with an added scope, not a doctor. I think sometimes people look at us as doctors, but I'm very clear that we're not, that we are nurses with an added scope. And with that scope, we can diagnose. So we can assess, we can diagnose, we can treat, we can order investigations, almost all investigations, although we're still pushing that practice. We can't do CTs, MRIs, there's still some room we've got to push. And then we can prescribe. And that scope has opened up over the years that I've been a nurse practitioner, definitely over the years. Jean's been a nurse practitioner. Kaitlan, you may have graduated to full scope, and that's always a challenge for us as nurse practitioners too, to have that ability to work to full scope. I would say in long-term care, it's not, we work to full scope, or I feel like we work to full scope, and there's not a question in long-term care about our scope, but other areas that NPs work, I think it is challenging. So does that make sense? Do you have any questions about who we are? No, okay. So what do we do in long-term care? The next slide. I guess we are all what we call attending nurse practitioners in long-term care. There are different models. There's what they call NLOT models, where they kind of come in, assess to prevent emerge visits. We actually are plunked in homes and work there for a full day, full time, more or less. So we're literally part of the team, which I think is what really makes our role work. And we really get to know the residents well and know the families and the staff, and we can build different things. So the majority of our time is spent clinically, I would say. There's kind of 4 different domains that an advanced practice nurse works out of. And I think we would all say probably 80–90% of our work is clinical. So that's seeing residents that are acutely ill, dealing with chronic illnesses, having conversations with families about levels of care, doing acute bedside things. And we can really, as nurse practitioners, take on a real holistic resident-centered care. And I spoke to it already, but a lot of what we do is building relationships with both the residents, the families, the staff. And then COVID has actually pushed this. The external supports are working much better. So internists, hospitals, because a lot of what we're trying to do is caring for them in our homes, not having them back and forth and out and about if we can manage them in-house. And then with that clinical also comes a lot of education at the bedside, because we can do and teach, which is the way most nurses learn, and because we're doers. And then we also do have like a formal role of education, formal role of research, incorporating best practice and quality care into what is happening at the bedside on a nursing level. And I would say that's more nursing focused. And the beauty of our job is I can still be a nurse in this role. I have not become a little mini doctor, which is wonderful, but I can work at an advanced scope. And then we do some administrative things. So we're often involved in like the professional meetings that would look at bigger things and developing policies and then doing stuff like this too. Here we go. I would stick under administration. And I thank RNAO for actually giving us this opportunity. They've been fantastic. So I am going to stop talking for a minute. What we decided to do, you can move to the next slide, Anne-Marie, is just talk to you about who we look after and then try to incorporate what a nurse practitioner and what a difference a nurse practitioner can make in a day-to-day life in long-term care. This is a photo of one of the homes I work at, Knollcrest Lodge. I work in southwestern Ontario, so Milverton, Stratford area, and you can see it's beautiful. But unfortunately, we have had to put up this awful fence to keep people out because of COVID. It makes me very sad to look at, but that's kind of our reality. You can see we social distance very well, but we've been able to get, like we do activities. She's doing her exercise program out on the front porch. So anyhow, so Kaitlan, your turn.
Thank you. And thank you, Sarah, for taking the time to be with us today and hear some of our stories. For some context as well, I actually work at 2 long-term care homes in Brampton. So I'm actually in the region of Peel, big hotspot, ground zero, it seems like. And I cover 2 homes, so I have 240 residents that I look after. So certainly a large patient group. In terms of the resident that I'd like to tell you about today, this is one of our frail seniors who had been in hospital. We'll call her Mrs. J. She is a 90-year-old woman, was admitted to us from hospital, unfortunately, after having a fall in her home and breaking her leg. And the bones did not heal well in her leg, requiring surgical repair and actually fusing the knee. So she lost her ability to actually be able to move one of her legs, that joint portion. And so had ended up essentially bedbound in hospital, very contracted, very stiff, and came to us with 6 pressure ulcers on her body, many of which were scattered on her legs, and a very, very large one on her bottom. I've never seen a wound that big in my career, and still haven't to this day. This is about four and a half years ago when I first started at the home. She was one of my first residents. And literally the wound on her bottom from hospital was probably the size of both of my hands. Very, very, very massive. And she had been admitted to us essentially to come to the home to die. The wound had become very infected all the way down to the bone. They felt that there was really no further options and treatment that they could provide for this woman. And so she was admitted to our home, and I saw her, and I saw this wound and was like, oh my goodness, how are we going to manage this? She couldn't easily, be going back and forth to a wound care specialist appointment. She would have required a stretcher essentially to get her there because of her mobility issues. There was no wound care specialist at the home. I had done a lot of my own education, taking courses in regards to advanced wound care, just because I knew how important it was, especially in the long-term care population, just having that skill set. And so every single day I would go and do this dressing change with the nursing staff. And because of my elevated scope of practice, I was actually able to debride this wound, so remove some of the dead tissue. And we actually started to get this wound to heal. I had knowledge of a lot of different dressings and different preparations that we could be using in order to help treat this wound. And of course, we had to look at things very holistically. So getting in the physiotherapist to address the mobility needs, getting her on therapeutic surfaces to make sure that we weren't causing more pressure, her being in bed, getting her a wheelchair that would actually fit her needs with this leg that was, you know, immobile, getting the dietitian in to assess her nutritional needs, and then getting her socially engaged as well, because she had been so bedridden and in the hospital for such a long period of time. And believe it or not, that wound is healed and that woman is still alive today. And I don't think that she maybe would have survived had there not been a nurse practitioner in-house who could address the complexity of this resident. And I think that's very, very important. It's not to say that maybe the physicians couldn't have handled it, but there wouldn't have been someone in that room every single day at the bedside, helping to engage the nursing staff and giving them the skill set to continue to do these complex dressings. And I think that we made a massive impact, certainly on this resident. And, you know, I think it's really important that certainly palliation is a huge part of long-term care. This is often the last home that our residents will have. They will pass away here. That's usually most of their wishes, is that they do pass away in their home. But I think the important thing is that, you know, we're not a hospital, but we should be able to offer these types of services to this population in-house. And we should be able to offer the fact that, you know, that they can keep living. They don't just have to come here to die, but we're providing a home where people can live until they die. And I think that's extremely important. As a result of, you know, obviously dealing with a lot of wounds with this resident, I was then able to take a step back and look at the organization's wound care policies. So I ended up, you know, moving from just one resident, but then starting to look at, okay, policy development, and being able to look at that lens first from a nurse, but also that medical aspect as well, and then pulling in best practice. And so we were able to then elevate our nursing policies in terms of wound care and look at that entire program and bring in evidence-based practice to really make quality improvement changes throughout the facility in regards to wound care. We ended up as well being able to implement in our point-click care system, which is where we put in our progress notes, and it's where all of the medical records are housed, a wound care app. So this really neat app where people, the nurses actually take an iPod to the bedside. You can take photos of the wounds. They do wound measurements. You can do your whole wound care assessment, and it gets integrated into this point-click care system. So it's a fantastic tool. And I was able to really advocate for that on the home level and the organizational level, to be able to get, you know, the funding and things to be able to provide, you know, that level of technology within the home. So, you know, big impacts organizationally as well. And certainly at the end of the day, it elevates the quality of care. The fact that we can provide these services in-house and then have the expertise to be able to link and make specialist referrals, you know, and do those sorts of things is extremely important. And lastly, just the education and training, certainly formal education that can be done to staff. I've done lots of, you know, formal PowerPoint education sessions to the staff, but then also that bedside nursing teaching that is so important, like Wendy had said, and usually how people learn best, just by watching and doing and really seeing something, you know, living and breathing that. So that's my resident story. Thank you for letting me share. And yeah, if you have any questions, or I don't know, maybe Jean wants to tell her story next.
I just think that's amazing,
Okay.
Kaitlan, really great.
Absolutely.
Yeah.
And thank you, Kaitlan, so much for sharing that with me. I think it's always helpful to understand, you know, the scope of the work that you do, and how having the right tools and the right team can really make a life or death difference for people. And I'll just share with you, Holland Christian Homes is literally up the street from where I live. So I see it every day. So now I will be waving and saying, hey, Kaitlan. but thank you so much for sharing that, because, you know, the seniors that reside in those homes, you know, they are a part of our community. You know, I see them at the Rexall when I'm, you know, picking up my own personal needs and, you know, at the Tim Hortons. And so I think it is really important that we don't just view these homes as a place for people to die. I think really understanding that this is a community, and finding ways to really support people, you know, in whatever ways we can is going to be so critical as we move forward. So really, thank you so much for sharing that with me, and Wendy as well for highlighting some of the work that you're doing as nurse practitioners, and the full scope of the work that you do as well. So thank you both. Definitely looking forward to the rest of the presentation.
Hi, Wendy, do I go next? Because I'd like to go back to the other slide with the 3 people. Okay, so I'm Jean. I'm a very seasoned nurse with 50 plus years of active nursing. And I've worked for the last 21 years, and I'm still working in rural, a medically unserviced area of Pembroke. When I first started, I was part of the initial pilot project of implementing nurse practitioner into long-term care. So we were parachuted in with not a lot of framework to work from, and our role was to figure out what would be the role for the nurse practitioner and what impact would this have on residents. So we've come a long way, because when I first started, we had a prescriptive list that limited what we could prescribe. And I used to go to the classes and say, well, it's obvious they want us working the sexual health clinics, because any of the antibiotics listed on that prescriptive list were for STIs, nothing to do with a pneumonia in a geriatric patient or a urinary tract infection. So inevitably, you know, it hindered practice in the sense that you were like a nurse calling the doctor to get a final okay. You knew what had to be done. And the docs used to say, well, you've done the assessment, why can't you just go ahead? And I said, well, I can't go ahead because we have a prescriptive list. So I'm very happy that that has changed, because it has certainly supported full implementation of the nurse practitioner. Anyhow, to tell my stories, I'm going to share with you my very first resident that I ever saw. Excuse the pics. I don't have, my people aren't living anymore, so, or they're not available, put it that way. So this gentleman got admitted, and the nurse, the RN calls me down because they're concerned he has a rash. They're worried that it's shingles. It's 9 o'clock in the morning. I go down, and here's this gentleman totally asleep in a wheelchair, and it's breakfast time. So I look at the rash and I tell the RN, no, this definitely is not shingles. It's some kind of seborrheic dermatitis, but anyway. But I said to her, I said, but you know, there's a bigger problem here. And she kind of looked at me and said, a bigger problem? And I said, yes, it's 9 o'clock in the morning and we can't wake this man. I said, whatever is he on? And it turned out he was on very potent, 4 different categories of potent antipsychotropic medications, which we do know is overused in this population. So I said to her, well, let's look at his meds. So it comes out to that. And apparently he had a history of becoming quite physically aggressive with staff. So I said, we need to change this, because we're talking about providing quality of life while they're with us. Sedating them out with psychotropics isn't the answer. So I call the doc and I take an earful from this doc that he had no qualms about sedating this guy, because nurses do not need to be the brunt of any physical aggression from him. And it just went on. And I said, well, I'm asking you to give me permission to taper those psychotropics. I'll monitor very closely. I'll, make sure that, I'll monitor. And he said, well, okay, and good luck. So I did gradually taper him off his psychotropics. He ended up off the psychotropic medication. He had a good quality of life, could ambulate. He wasn't even, because he was so sedated, he hadn't been eating also. So about a year later, when the doc came in to see him, he actually wrote in his medical progress note, a special thanks to nurse practitioner Jean Benton for the great work she has done with this gentleman. And to me, that was such a positive feedback of, showing to the staff, this is not the answer for managing these people. And, you got to pay attention to the medications, because we do know there's a big overuse of medications in this population. And so why now deprescribing has become really very evidence-based for quite a few of the meds we can pull back on. So that's that first positive. And I think I share it because I think it demonstrates, had the nurse practitioner not been there, there wouldn't have been creating this awareness in staff that there is a better way to do things. And it's supporting the staff, because let me tell you, I did that withdrawal, but I was down there to see him and talk to the staff and support them in their non-farm interventions. So that's a key role. And NPs are a great clinical resource. We need a knowledge-based staffing, and NPs can help develop the staff skill set. The other lady I want to talk about is a lady. We do have 3 community hospice beds here. They're designed for persons coming in from the community. And this lady got admitted. So I go up to see her do admission. And I took one look at her and I thought, this lady doesn't really look like she should be in hospice. And the story was, what I really felt gut-wise is that she was in a severe depression. What had happened is this lady had lost her husband had died in the year. And her background was she was very dependent on her husband and never learned to drive. He managed all the finances. As she would say to me, I wanted something, he always gave it to me, whatever I wanted. She wanted to go on a trip, they went on a trip. After he died, of course, finishing up affairs, she finds that he has left them bankrupt. She has absolutely no money. She has never learned to drive, and she's been told she's going to have to consider going into a retirement home. And so the social worker had given her all kinds of brochures on different retirement homes. And I'm thinking, well, she's not really a retirement home resident, but anyway. So I said to her, what I'm picking up here is that you're very acutely depressed, and I'd like to start you on antidepressant therapy. She responded so well. She got discharged from hospice. She's now living in the community, has a new partner, and has learned to drive. And she comes to see me to thank me for having done this for her. Because she had overdosed on some opioid medication, and that's how she ended up in the hospital. And from my perspective, had just been pushed aside, saying, there's nothing more we can do with you, you're going to die. So that's another, we have a lot of discharges once we treat what the person has. The other one I want to share with you, because it also shows you how as NPs, we really need to support the psychosocial care of our dying. So this was, she wasn't quite as old as that picture is, but a lady dying of ovarian cancer. And I walk in one morning to she was in our hospice beds, and the husband is sitting there, her partner is sitting there, saying that, he's just looking so forlorn. He's just like this. So I said to him, I said, you look very, very down today. And he said, yes. He said, there's 2 wishes Alice wanted before she dies. And she knew she was dying, okay. And he said, the first one, it's not possible. She wanted to go on a trip to some special area. That was her favorite place to go to. Her second one is that they had never formally married. They lived together, but had never got married. And she didn't have a wedding ring on. And her wish was, before she died, she wanted to be married and wear a wedding ring. So this is a Friday. So I'm hounding I go down and see pastoral, and I say to the pastoral person, there's a last request to perform a marriage ceremony for a lady in hospice. And he gave me the shove off in terms of, well, she's not of the church that I'm of, and this is too rapid of a notice. There's no way we can do this, make it work. So I said, well, she's of this dominion. So I said, please find me a minister from that dominion and I'll talk to him. And so he came, I finally got a minister who very begrudgingly, I have to say, because I argued hard, there was not time. I mean, this lady only had, if anything, 24 hours left in her life. But I said she wants to die with the wedding ring on her finger. I said, you've got to make an exception. So we organized the wedding ceremony around her bed. The nurses, we didn't have even any fresh flowers to give her, but they got all these, the plastic ones that we use or the fake ones. And the nurses gathered that around. So with us nursing staff around the bedside, this lady received her wedding ring. And it was her last moment, and she died shortly after that. So that's the difference we make in the impact we have on residents. Anyway, I've probably rambled on too much because I've got lots of stories to tell. That was my hardest part. Which ones do I talk about?
Well, they're all priceless, Jean, and really show the focus on quality of life, but also the confidence that comes with your role in terms of really knowing how to dialogue and negotiate and interact with various healthcare professionals and your own team. So I think that's absolutely great.
And it's a result of building up relationships because, you have to have relationships with everybody. The good working relationships with the staff, you're not there to be criticizing them or supervising. And that's why I always tell them, look, I'm not your supervisor. I'm a colleague. I'm working along with you. So, yeah.
If I can say, Jean, thank you so much for sharing those stories. And they literally brought tears to my eyes because I think it really highlights and underscores the importance of having advocates within the system and nurse practitioners like you and like Kaitlan and everybody else on this call stepping up and, trying to, through whatever means you can, ensure that quality of life and quality of care is present in the system for folks during some very trying times. I'll just share a personal story. I lost my brother a few years ago, and as you were sharing the story about the person that wanted to get married, that was his last wish as well. And so, unfortunately, we weren't able to make that happen for him. But the fact that somebody like you advocates for the people you're caring for, it makes a world of difference, not only for that person, but for their families as well. And so just thank you so much for sharing that, because I think it, again, just underscores the importance of having people like you in the system that care and truly want to see the best outcomes for the people you're supporting, whether that's making sure that they're on the right medication and that they're not over medicated and that they can live their lives to the fullest, or advocating for their final wishes. It's a very powerful thing that all of you are doing. And so just thank you so much again for all the work that you're doing every single day.
Thank you.
I think it's also important, before we move back to Wendy, to reinforce not only the quality of life as outcomes, however, the impacts on family and others that then impact the cost of health care. I dare say, Jean, the husband of your last client probably would have been in a very different situation and mental and physical state if this was not able to be carried out, and probably required treatment, costing the system. And again, the prevention of going to hospitals and someone being over medicated, that all costs a lot of money to the system. So it really is double as I see it, the quality of life as well as the quality of our system with dual impact on costs. Anyway, Wendy, sorry.
Oh, we could talk all day. Okay, next slide. So we decided most of what we do is look after older folks. I think people know that. Like, they tend to be the majority frail seniors, which is why we do what we do. But then we get the Joannes in our lives, and there's actually more Joannes than what you would imagine when you walk through our facility. So she is the youngest one I look after. She's 48 years old, has lived in long-term care since her late 20s. And will live in long-term care for years, hopefully years to come. And then my oldest right now is about 102. And I've got quite a few that are younger with mental health. So Joanne's got multiple sclerosis. She's got MS. I actually, because I'm local, I actually played soccer with her. So I remember the summer when she was diagnosed. She used to come off the soccer field and go, oh, fuck. Right? She would swear. She's a great swearer. I can't see a thing. I can't see anything. And she'd trip over her legs. And so when I actually care for Joanne, it's like, oh my, I see that young woman who could play soccer. She's wonderful. But anyhow, so she's lived in long-term care for years. I think, what difference have I made in her life other than to have some fun and talk soccer and tell everybody else around us how good she was at playing soccer? When I came onto the picture, I started attending family conferences. So in long-term care, we do annual conferences. We tend to meet after 6 weeks in just to review how are we doing, what are we missing. And at one of these care conferences, it came up that she had not had a PAP, right? Our routine screening. She was in long-term care at the age of 29, 30, or a breast exam, or like anything that we typically do for a well 40-year-old. So I was like, okay, well, I can do that. I'm a nurse practitioner. I've got time. I can, right? This is what we do. We do routine health screening. And lo and behold, I find a big mass about the size of a golf ball in her left breast. And we are pretty good in long-term care. Like, the staff see skin all the time, but she's got breasts, right? Like, they're not 90-year-old breasts. I don't know if you've seen 90-year-old breasts, Sarah, but they tend to look different. And you would see a golf ball size tumor in a 90-year-old breast. It can be missed in a 40-year-old who's got some good breasts, sorry. So we diagnosed her with breast cancer, and it was actually quite extensive at that stage. She ended up going on to having chemo to see if it would shrink, and that was all interesting because she would flip-flop, and she has some cognitive impairment, but you wouldn't know it in conversation. So part of my role was to tell the surgeons and to tell, you cannot just go by what Joanne says. She actually does. So I did some testing, right, to show them that she's not competent, even though she's 40. You need to speak to her power of attorney, not Joanne, when you're making decisions, because she's actually not capable. So I did that piece of it as well, which comes with that geriatric piece, because she really didn't understand and still doesn't know that she lost a breast, which is a beautiful thing. But she ended up having chemo because she wanted to keep her breasts, and then it didn't shrink enough, and they ended up removing the whole breast, which was probably the best thing in hindsight for her. Through that as well, then she did go to London, right? You do this mobility bus, you get them to London for what, a 2-minute appointment with the specialist who says, oh, everything's okay, send her back. That costs her and her family huge dollars. And really, they don't get the right story because Joanne can't tell you how she feels on tamoxifen right now, right? Like, I feel fine, but you don't get the real story. So what we started to do, and COVID really made this work beautifully, is now they can't go. So they actually call. We actually have appointments that we do with specialists on all levels. I do it with our follow-up hips that are done with surgeons. They don't go back and forth. We do local x-rays, and I just do phone calls or virtual with the surgeons. I do it with oncologists on a regular basis. I've got 2 out of my 120, which is not a lot, but a few that we have routine appointments with. We can do it with all. I've done it with urologists, I've done it with neurologists, with geriatricians. So they're actually using us. And when they call us, we can give them what they need because we know them well, we know their history, we can do the assessment piece, and we can give them what they need. The other thing cool that we did for Joanne, and she's breast free. I just ordered her routine follow-up mammogram today, her surveillance, and did a breast exam every 6 months. And I'll keep on top of that, right? Like that's just what we do. The other thing we've done for her is because of her MS, she's got some spasticity, so they can get into contractures and issues with skin, as Kaitlan kind of spoke to as well. I've actually set up, it was ready to go pre-COVID and then we had to stop it, but I actually connected and have set up for a neurologist to come out to our homes. And he comes out every 3 months and he assesses people like Joanne, who may have contractures, like your lady. I don't know if you do this, Kaitlan and Jean, but and he can do injections like Botox type injections into their muscles to relieve some of that contracture. And so again, we can make more happen to prevent long-term kind of awful side effects. Because if you don't manage those, they get severe pain, they can get big breakdown, skin breakdown, and run into a lot of problems. So I guess that's what we've done for Joanne, or as a nurse practitioner, what we've done for Joanne. What else did I want to say? And I just wanted, like, she's going to live with us for years. So this is truly a home. And we take people like Joanne right up until end of life care. And if they come a year before they die, 2 years before they die, we do that. And I guess the one big push I would have on a higher political level is we need to get rid of some of this craziness around visiting in long-term care through COVID. So I've had 4 deaths in the last week between my 2 homes. And I can tell you it has been more painful for families now than it was at the beginning of COVID. And it's because they feel like they've lost a whole year of life that was there. And because we're in this lockdown mode, you can only let 1 person in at a time to sit at a bedside. That is a directive that comes straight from on high, that we cannot, my management at both homes will not break those rules, because we see people being punished in other homes for breaking a rule. So I had a wife yesterday, a spouse of somebody dying. I saw her at her son stayed overnight with her dying husband. I saw her as she was coming in the morning to say, she was texting him saying, I'm here, you can come, I'm coming in. She looked at me and she said, can't we both be in there together, right? Tears, I'm gonna cry. Right? Like, I can't imagine sitting around a bed, somebody dying alone. It's not right. So if you can make a difference with something like that for us, I'm going somewhere else, but that would be beautiful. My next little lady, bring Mary up quickly, and I won't talk much about her because Kaitlan covered a lot of things. She was another woman who came in with big, huge wounds. All she wanted to do, Mary, was walk, and she had a big wound on her heel that we managed to heal. I actually got a podiatrist in. We got an offloading shoe. This is her walking with me through COVID. Then she would desat and pass out when she'd walk, so nobody'd want to walk with her because of those risks. So here I am, because I'm like, yeah, she wants to walk. This is what we're going to do, is walk. So we did get her on oxygen. We tried some CPAP with her that didn't work, but there's a lot of things as nurse practitioners you can do and support. And like Kaitlan, we now have a good compression program going in both of our homes, right? We can affect policy and practice at a very different level than what a physician can. I love physicians. I've worked with fantastic physicians. I personally wouldn't want to do it alone. Like I love having that consult support and somebody who knows them. And it's about the team. It's about working together, and we all have different roles in that and skills, but there definitely is a role for nurse practitioners in long-term care. Definitely. It's actually why I went in. Yeah.
I was just going to say, Wendy, I love in all of your stories, what you do is in a confident way based on your knowledge. And I just see that coming through, and I'm sometimes not sure you're really appreciating that you can say, of course I'll walk with her. I know what will happen. I know how to address it. And we're not talking that your colleagues are necessarily all PSWs. So they're registered nurses and registered nurses, but they do not have these.
Yeah, I am. I'm in a meeting right now, so it should end and I'll call you.
Let me turn this over to you, Kaitlan, because I know you wanted to take that segue and that Wendy started about COVID and maybe share some of the COVID experiences and then be able to hope that Sara, you're out there promoting all those recommendations from the commissioner's report.
Yeah.
Okay, Kaitlan.
Absolutely. Thank you. I know we don't have too much time left, but we did want to squeeze in a little bit about COVID because this has been our reality now for well over a year, unfortunately. And I think the NP role, especially during COVID, it was really interesting. So unfortunately, both of my facilities ended up having quite major outbreaks. So one of them had a significant outbreak in wave 1 of COVID, and the other facility had a significant outbreak in wave 2. Fortunately, in wave 3, we've had some just minor ones, and we've been able to manage that quite nicely. But my one home was one of the first long-term care facilities to have a COVID-19 outbreak. And at that time, we didn't know nearly what we know today. It was so new. People were terrified. Ministry directives came down with, I think, no real consultation of people on the front lines in major positions. Like, I think even the three of us could have told you, some really major implications of what some of these directives would have had on the facilities. The one being that all of a sudden staff can only work at one location. Long-term care has been understaffed for years, and now you've just cut the workforce by a third. Plus that, you've got a deadly virus circulating. People are running for the hills because they're terrified of bringing a virus home, or getting it themselves. And I think what we, as NPs, what we tried to do a lot during the COVID-19 outbreak and continue to do is advocate for the long-term care sector from the ministry level, public health, the LIN, local hospitals, what we need in long-term care. And especially, when things are changing so quickly, we have a unique lens that we understand things quite well medically. And when public health, for example, is giving advice to a home that does not make sense necessarily, maybe from a medical perspective, and maybe understanding the sector that we're dealing with, we had the ability to really push and ask questions, push back. In wave 1, you could barely get swabs to test people for COVID-19. So when you can't get swabs and you're completely barred by the fact that public health will not allow you to test, I don't know how you're going to manage an outbreak. And so, pushing back and really, really pushing the limits and saying, we have to do something, and testing is the only way you're ever going to get control of an outbreak, is something that me as an NP, I had to be on those calls and make those decisions and bring that to the organizational level and have discussions with our medical director. And I think we would have been a heck of a lot worse off had we not been really pushing the limits and trying to make those tough calls. I think in terms of NPs, we're really good at pivoting. That's a word you probably hear a lot. You never really know what you're going to walk into each day. We tend to wear a lot of hats. So we deal with things clinically and then turn on a dime, and then you're trying to figure out a new policy based on directives and how you're going to help the home implement that. We're excellent at communicating as well. So during COVID, when you're completely short-staffed, families are panicking because now they've been barred from the facility. You've lost, you know, so much of your workforce. We were there communicating with families or advocating for bringing people in to start communicating with families. We were actually able to advocate to our local LIN to actually give us a care coordinator during one of our outbreaks to all day call every single family of every single resident to keep them updated, because communication was key. You know, I think we have a lot of challenges still in long-term care. The acuity in the long-term care sector of the residents that are coming into the homes is extremely different than what it would have been 10, 15, 20 years ago. You may have had, you know, some very functionally actually independent people coming into long-term care who would then stay for long periods of time. And now you've got younger populations, or the extreme end of the spectrum where they're coming in their late 90s or 100, extremely sick, extremely frail, and extremely complex. And really the nursing and PSW skill set and staffing ratios have not kept up with those changes. And so advocating for increased staffing and increased skill sets in long-term care, and giving people, I think, the tools and educational opportunity to want to stay and work in this sector is extremely important going forward for the future. And I really do think that, you know, continuing to advocate for nurse practitioners in the home in every long-term care facility, and I think the ratio of 120 is very reasonable, would be excellent, because we can do so much in-house. And I think just even hearing some of our stories today, we've made drastic improvements, you know, within the long-term care facility and the quality of life, you know, for our residents and their families. So I'm not sure if Jean and Wendy, you have some things to add. Jean, you're on mute.
Sorry about that. I just also want to add the issue that the increasing acuity of residents and the staffing levels, and it isn't just staffing levels. I think we need to be very strong in what is an appropriate staffing mix, because in this present facility I'm in, we have very minimal RN staffing, and I think what's happening is we're getting the PSW RPN staffing, but what we truly need is we need more registered nurses in long-term care. They've been let go over time, kind of thing. And when you have one RN that's a supervisor for 6 units in a 12-hour shift, there's little supervision that can be done by that particular single RN. So we need to advocate for the nurse practitioner employment in long-term care, but also we need an adequate ratio of RN. And that's why I really do support RNA's O's staffing mix of at least 20% RN staffing. And you're absolutely right. The acuity is their palliative as they're coming through the door because they're end-stage chronic disease. We don't get them